Welcome back to the deep dive. Today, we are tackling a topic that, I have to say, sounds like the title of a Victorian mystery novel or, maybe a psychological thriller.
It does, doesn't it?
We are looking at the right hypochondriac mass.
The case of the right hypochondriac mass. But for a surgeon or a medical student standing at a patient's bedside, it's definitely not fiction. It's a very, very high-stakes puzzle.
I can imagine.
And frankly, it's often a source of some significant anxiety.
I bet. And just to clear the air right at the start, because I know what everyone's thinking. When we say hypochondriac here, we're not talking about that friend who thinks a common cold is a terminal illness, right?
No, not at all. We're not analyzing personality quirks today.
Good.
Although the etymology is actually the same. It comes from the Greek hypo, meaning under, and chondros, which means cartilage.
Oh, interesting.
So hypochondrium literally means under the cartilage. In anatomy, it refers to the upper regions of your abdomen, the parts tucked right under the rib cage.
So the right hypochondrium is just that upper right corner of your belly.
Exactly. We're talking pure geography, high-value real estate in the body.
Right.
And when you find a mass there, a lump, a swelling, something that shouldn't be there, it really does initiate a very serious countdown.
So looking at the source material we have for today, which comes from the teachings of Dr. Senthil Kumaran, an associate professor of surgery, there seems to be this common theme of panic.
Yes.
He describes students encountering this mass and just, freezing.
It's the blank mind syndrome. It happens. You feel a lump, and suddenly all that textbook knowledge just evaporates. Dr. Kumaran points out that the immediate instinct for a trainee is often to just abandon clinical reasoning.
And just start memorizing lists.
That, or they start memorizing random lists of diseases. Or, even worse, they panic and try to solve the whole thing with technology.
You mean the shotgun approach?
Precisely. They just order a CT scan, an MRI, blood work, maybe a biopsy, all at once. They just fire everything and hope one of the pellets hits the diagnosis.
Which, it sounds inefficient, but on the other hand, isn't that safer? Just check everything.
You'd think so, wouldn't you? But no. It's actually dangerous. First, it's incredibly wasteful. But more importantly, if you don't know what you're looking for, you might completely misinterpret what you see on the scan. Or you might find something totally harmless, an incidentaloma, and start chasing that while the real killer gets missed. And in the worst case scenario, which we will definitely get to, doing the wrong test, sticking a needle in the wrong lump, can actually kill the patient.
Wow. Okay, so the stakes are officially raised.
They are. So our mission today is really to take Dr. Kumaran's framework, which is designed specifically for upcoming surgeons to build that confidence and to just break it down.
From chaos to clarity.
We're going to move from a pile of disconnected facts to a coherent, safe, clinical thought process.
I love that. We're applying discipline to the chaos, and we have a roadmap for this deep dive. We're starting with the geography, the surgical anatomy. Then we'll look at the suspects, who actually commits crimes in this area. Then the interrogation, the history, the search, the physical exam, and finally, the verdict.
It's a solid plan. And it all starts with that geography. If you don't know the territory, you can't possibly catch the criminal.
Okay, so let's define the box. If we are, standing inside the abdomen, looking at the right hypochondrium, what are the walls? What are the strict boundaries?
Okay, so visualize a box in that upper right quadrant.
Yeah.
The superior boundary, the ceiling, is the diaphragm. But the structural beam that defines that roof, for us, clinically, is the right costal margin.
That's the bottom edge of your rib cage.
That's the one.
So the ribs are kind of like a bony awning over this whole porch.
That is a perfect analogy. It's a bony awning. And in a healthy person, the contents of this box are all tucked away behind that awning. You really shouldn't feel much below it.
So if you feel something sticking out past that awning, something is wrong.
Something is definitely wrong.
Okay, that's the roof. What about the floor of the box?
The inferior boundary is what you call the subcostal plane. It's basically an imaginary line drawn across the lowest part of the rib cage.
Got it.
The medial boundary, the inner wall, toward the center of your body, is the epigastrium, the area right over your stomach. And the lateral boundary is the right lumbar region, moving out towards your flank.
So it's a tight space. This isn't a sprawling field. It's more like a closet. Who lives there? It sounds crowded.
It's basically a crowded elevator. And obviously, the biggest tenant, the one taking up 80% of the space, is the right lobe of the liver. It just dominates the room.
The heavyweight champion.
Exactly. But then tucked strictly underneath the liver, almost like it's hiding in the liver's shadow, is the gallbladder.
So the liver and its little sidekick.
or its troublemaker, depending on the day.
Hmm.
Then you have the hepatic flexure of the colon.
Hepatic flexure, that's just fancy talk for where the colon turns a corner.
Right. That's all it is. The large intestine comes up the right side of your belly, it hits the liver, and it has to make a hard left turn to go across. That corner is the hepatic flexure, so that's in the box too. Then you have the first part of the duodenum, and tucked further back, kind of hiding in the retroperitoneum, the space behind the main abdominal cavity, you have the upper pole of the right kidney and the right adrenal gland.
Whoa, hold on. You just listed half the vital organs in the body. You've got the liver, the gallbladder, the colon, and the kidney all specifically in that one upper right corner.
Yes.
How does a doctor even begin to tell them apart just by touch? They're all just squished together in there.
It is a challenge. And that is exactly why Dr. Kumaran shares his first major rule of surgery here. He says, in abdominal surgery, anatomy narrows diagnosis faster than investigations.
Meaning?
Meaning, if you find a mass in this specific box, it must arise from one of those structures we just listed. It didn't teleport there from somewhere else. It's not a heart tumor. It's not a spleen issue. It has to be liver, gallbladder, colon, or kidney.
So the list of suspects is finite.
It's finite. You just have to know who lives in the neighborhood.
Okay, so let's line up those suspects. Based on that anatomy, we can start to group the causes. Who are the heavy hitters here?
You group them by the organ of origin. So first, and by far the most common, you have the hepatic causes issues with the liver itself. This could be just a general enlargement, which we call hepatomegaly.
Or it could be a specific lump.
Right, a focal mass, like a tumor. The big bad one is hepatocellular carcinoma, liver cancer. But it could also be an infection, like a liver abscess, or it could even be parasitic, like a hydatid cyst.
Okay, so that's the liver gang. Then we have the gallbladder gang.
Right. The main ones there are carcinoma of the gallbladder, so cancer, or a mucus cell.
A mucus cell, what is that? It sounds gross.
It is, a bit. Imagine the exit door of the gallbladder gets blocked, usually by a stone. The gallbladder just keeps making mucus, but it can't get out. So it swells up like a big, tense water balloon. That's a mucus cell.
Got it. And the others, the colon and the kidney.
Well, you can have colonic causes, specifically cancer. At that bend we talked about, the hepatic flexure carcinoma. And you can potentially have renal causes, like an enlarged right kidney.
But you sound hesitant about that one.
I am. And this is a really crucial nuance that Dr. Kumar emphasizes. An enlarged kidney is rarely palpable in this specific anterior zone.
Why is that?
Because the kidney sits way, way in the back. It's retroperitoneal. When it gets big, it tends to bulge into the flank or the loin, not right out the front under the ribs.
So if I'm a student taking an exam or a doctor in a busy clinic and I feel a lump right there in the front, I shouldn't be betting on the kidney.
Exactly. Focus your attention on the liver and the gallbladder. Those are your heavy hitters. Statistically, anatomically, it is overwhelmingly likely to be one of those two.
Okay, so we know the territory and we have our prime suspects. Now comes the part I find absolutely fascinating, the interrogation. Or, in medical terms, the clinical history.
This is where the real art of medicine comes in. There's a saying that a good clinician can make the diagnosis 80% of the time just by talking to the patient before they even lay a hand on them.
That sounds like a magic trick. But here, it's really just about asking the right questions. Let's walk through the specific lines of questioning our expert source recommends.
The first differentiator, and maybe the most important one, is time. The duration of the symptoms. Is it acute? Did it happen suddenly over a few days? Or is it chronic? Has this been brewing for months?
And what does the speed tell us?
Speed tells us about the nature of the underlying process. An acute onset strongly points to inflammation or infection. Think about a liver abscess.
Let's dig into that for a second. The liver abscess. What is actually happening in the body there?
It's essentially a biological explosion. You have bacteria, maybe from a burst appendix or some kind of gut infection, that have traveled up the portal vein, which is like a superhighway, straight to the liver. They set up camp, and they just start destroying tissue, creating a pocket of pus. This isn't a subtle process. This is a war zone. And that's why the onset is acute. The body is screaming.
Okay, so fast usually means infection. War zone, what about slow?
A chronic onset, something that's been slowly growing for months, points you toward malignancy cancer, or something like hydatid disease, which is a type of cyst that grows very, very slowly, almost like a balloon filling up with water over years.
Right, so speed tells a story. What about pain?
Pain analysis is critical. You have to ask about the character of the pain. If it's a liver abscess, that war zone we talked about, the pain is typically constant. It doesn't come and go. It just throbs. It's a dull, aching, heavy pain.
Is there any specific weird referral pattern? I always love those, where the body gets its wires crossed.
Yes, actually a classic one.
Yeah.
A liver abscess can cause shoulder tip pain.
Wait, pain in the shoulder from a liver problem? That seems completely disconnected.
It does seem random, but it's basic wiring. Think of your nervous system like the electrical wiring in a very old house. The liver sits right under the diaphragm.
Right.
If you have an abscess on the top of the liver, it irritates the diaphragm. The nerve that supplies the diaphragm, the phrenic nerve, enters the spinal cord up in the neck, specifically at levels C3, C4, and C5.
Okay. Stay with me here.
Now, here's the key. The nerves that sense pain from the skin over your shoulder also come from C3 and C4. So when that distress signal screams up the phrenic nerve from the diaphragm, the brain gets confused.
It's a cross signal.
It's a phantom phone call. The brain sees a signal coming from level C4 and just assumes it must be the shoulder. So the patient is rubbing their right shoulder, but it's their liver that's crying for help.
That is wild. It's a literal cross connection. So if they're rubbing their right shoulder and they have a fever, check the liver.
Absolutely.
What about gallbladder pain?
Carcinoma of the gallbladder often presents with a dull, persistent pain. And the real tragedy there is that it often presents very late. It doesn't scream at you until it's quite advanced.
So it's a silent assassin.
It is. Unlike the abscess, which is angry and loud, cancer is often silent until it's too late.
Moving on to fever. You mentioned the war zone of the abscess, so I'm assuming that comes with some heat.
It does, but the type of fever is important. It helps you distinguish the invader. If you have a high-grade fever with shaking chills, what we call rigors, that suggests a pyogenic abscess.
Pyogenic meaning?
Pus-producing. It means a bacterial infection. The bacteria are pouring toxins into the blood, causing the body to shake violently to generate heat. It's a full-on systemic storm.
And if the fever is more low-grade?
A low-grade fever, often just in the evenings, would suggest an amoebic abscess. It's a parasitic infection, usually from Entamoeba histolytica. It's less violent than the bacterial type, but still very dangerous.
And if there is no fever at all?
That usually points you toward malignancy. Cancer doesn't typically cause a fever until the very end stages of the disease.
Okay, next clue. Jaundice. The yellow flag.
Jaundice is a major red flag in the right hypochondrium. If you have a mass and the patient is yellow, it suggests obstruction.
Like a plumber's blockage.
Exactly. Bile needs to flow from the liver, through the bile ducts, and into the gut. If you have a mass, say, a gallbladder cancer growing into those ducts, it physically pinches them shut. The bile backs up into the blood, and the patient turns yellow.
So it's never a good sign.
It's never a good sign in this context. It usually implies the disease is quite advanced.
What about the general state of the patient? Things like weight loss, appetite?
These are what we call constitutional symptoms. Significant weight loss almost always screams malignancy. Cancer is a parasite. It just burns through the body's energy to grow.
And what about appetite? Dr. Kumaran highlights a specific red flag, anorexia.
Right, and we're not talking about the eating disorder. In this context, it just means the medical definition, a complete loss of appetite. But it's profound.
How so?
If a patient looks at food and feels nauseous, or just has zero desire to eat, and they have a mass, you have to think cancer first. It's as if the body knows something is deeply wrong and shuts down the desire for fuel.
Now, let's talk about the backstory, the past history. This feels like where the detective really starts digging into the suspect's old files.
It is exactly that. You're looking for risk factors. For example, does the patient have a long history of gallstones?
But lots of people have gallstones, don't they?
They do. But if they've had symptomatic gallstones for 20 years and they've just ignored them, that chronic irritation is the #1 cause of carcinoma of the gallbladder. It's a slow-motion car crash.
What about travel history?
Crucial. If they have a history of travel to areas with poor sanitation or a history of dysentery, bloody diarrhea, you have to think amoebic abscess. The amoeba starts in the gut, causes the diarrhea, and then migrates up to the liver to form the abscess.
And my favorite one, just for the sheer weirdness of it, animal exposure.
Right. This is for hydatid disease. If the patient lives on a farm or has very close contact with sheep and sheepdogs, you must consider it.
Sheep and dogs. Explain that connection to me.
It's the life cycle of the parasite, Echinococcus granulosus. The adult worm lives in the dog's intestine. The dog poops out the eggs. The sheep eats the grass that's contaminated with the eggs. Cysts form in the sheep. The dog then eats the sheep meat, and the cycle continues.
And where do humans fit in?
Humans are accidental hosts, a terrifying phrase. We accidentally ingest the eggs, maybe from petting the dog and not washing our hands, and the cyst forms in our liver instead of the sheep's.
So just by asking out these things, duration, pain, fever, jaundice, weight loss, and backstory, we've probably narrowed our list from 10 suspects down to 1 or 2.
Before you even touch the patient.
But eventually you do have to touch them. Which brings us to the search, the clinical examination.
The hands-on phase. But Dr. Kummerin is very strict about this. Keep your hands in your pockets first. Use your eyes. Inspection.
What are we looking for from the foot of the bed?
You look at the abdomen. Can you actually see a fullness in the right upper quadrant? Sometimes the mass is so big it distorts the shape of the belly. Can you see it moving when they breathe?
What else?
Is the patient jaundiced? Are they cachectic?
Cachectic is such a grim word.
It is. It means severe muscle wasting. You can see their ribs, their temporal muscles are sunken. It looks like the body is consuming itself. That strongly suggests advanced cancer.
What about veins on the stomach? I've heard of caput medusa.
Yes, dilated veins radiating from the navel, looking like the snakes on Medusa's head. It means the liver is blocked, usually by cirrhosis or cancer, and the blood is trying to find a detour back to the heart. It's a sign of very high pressure in the portal system.
Okay, inspection's done. Now, palpation. Touching. This seems to be the critical step. What are your hands trying to feel?
You're assessing 4 key things: size, surface, consistency, and tenderness. But before any of that, you have to confirm where the mass is coming from. And there is one maneuver, one biological truth that determines everything.
This is our second major aphorism.
Yes, a liver that does not move with respiration is rarely a liver.
Let's unpack that because it sounds simple, but the mechanics are so important. Why must the liver move when you breathe?
Think about the anatomy we just discussed. The liver is basically fused to the underside of the diaphragm. The diaphragm is the engine of breathing. When you take a deep breath in, the diaphragm contracts and pushes down like a piston to open up your lungs.
Right.
Because the liver is physically attached to that piston, it has no choice. It must ascend. So if you have your hand on the patient's belly and you ask them to take a deep breath, you should feel that mass slide down and meet your fingers.
And if it doesn't move?
If the patient takes a huge breath and that mass stays perfectly still, it is very likely not the liver or the gallbladder. It's probably retroperitoneal, like a kidney mass that's stuck to the back wall, or it's a mass in the abdominal wall muscles themselves. This is the definitive test.
Okay, so let's say it moves. We know it's probably liver or gallbladder. Now we feel the texture. How do we differentiate the suspects by touch?
This is where you need what we call intelligent fingers. If it's simple hepatomegaly, just an enlarged liver from something like heart failure, it moves nicely, it has a smooth edge, and it feels firm but sort of elastic.
And what about the war zone, the abscess?
An abscess will be tender. The patient will flinch when you press. You might even feel guarding, which is where the abdominal muscles involuntarily tense up to protect the inflamed area underneath. It's the body saying, "Do not touch me here."
And the really bad actor, the gallbladder carcinoma.
Hard. Dr. Kummerin describes it as a hard mass. It feels irregular, craggy, like a bag of rocks. And often, frighteningly, it is non-tender.
That doesn't hurt?
Often, no. Because cancer tissue itself doesn't have pain receptors in the same way that inflamed tissue does. So you feel this hard, rock-like lump that doesn't hurt, and that mismatch is terrifying to a doctor. Hard plus painless plus jaundice usually equals cancer.
So, to summarize, tender and softish probably equals abscess. Hard, irregular, and painless probably equals cancer.
Generally speaking, yes. That's the pattern you're looking for.
We also have percussion and auscultation. Tapping and listening. Are these as useful?
They're supportive. Percussion helps you find the upper border of the liver so you can tell if the liver is actually enlarged or if it's just been pushed down by a lung problem like emphysema.
And listening with a stethoscope. I can't imagine the liver makes much noise.
It shouldn't. It's a solid organ. But very rarely, you might hear something called a bruit, a whooshing sound, like water rushing through a narrow pipe.
What would cause that?
Hepatocellular carcinoma. Liver cancers are incredibly vascular. They build their own chaotic network of blood vessels to feed themselves. The blood rushes through these messy vessels so fast it creates turbulence.
So you can actually hear the cancer.
You can hear the blood flow through the cancer. If you put your stethoscope over a liver mass and hear, whew, it's almost certainly cancer.
Okay, we've grilled the suspect, we've searched the scene. Now we need the forensics, the lab, investigations.
And here we have to go back to our earlier warning about the shotgun approach. Dr. Kummerin is adamant. Do not order tests blindly. Investigations must be strategic. They are there to confirm what you already suspect from your history and exam.
Be a sniper, not a shotgunner.
Exactly. Start with the basics. Baseline tests. A CBC, a complete blood count to look for infection-high white cells, suggest an abscess. If the white cells are normal but the patient is wasting away, you think cancer.
And liver function tests?
LFTs tell us if the plumbing is blocked. They tell us how the liver is coping.
Then we move to pictures. What's the first-line imaging tool?
Ultrasound. Always ultrasound first.
You know, in TV shows, they always scream, get me a CT. Why not just go straight to the high-res CT scan? It sees everything, right?
It does, but there are several reasons to start with ultrasound. It's cheap, it's available everywhere, and it has zero radiation. But medically, it is excellent at one very specific thing, telling the difference between solid and liquid.
Liquid being a cyst or an abscess, and solid being a tumor.
Precisely. An ultrasound sends sound waves. If they hit water, like in pus or cyst fluid, they travel right through. If they hit a solid rock, like a tumor, they bounce back differently. An ultrasound can instantly tell you this is a bag of pus or this is a solid mass, and that changes your entire management plan in seconds.
And I guess it can guide a needle if you need to drain something.
Correct. But if the ultrasound looks suspicious, if it sees a solid mass or an irregular-looking cyst, then we pull out the big guns, the contrast-enhanced CT or CECT.
What does the CT give us that the ultrasound didn't?
The roadmap. The CT defines the extent of the disease. It shows the relationship to all the critical blood vessels, the portal vein, the hepatic artery. It tells the surgeon, is this operable? Can I cut this out safely without hitting a major vessel? You never ever go into cancer surgery without a CT map.
And what about special tests for our specific suspects?
Yes. If you suspect hydatid disease, that sheep parasite, you do serology blood work looking for antibodies against the parasite. If you suspect liver cancer, you check tumor markers like AFP, alpha-fetoprotein.
Okay. We have arrived at the verdict. We're pretty sure we know what it is. Now, what do we do about it? Let's run through the management for our main lineup.
Let's start with general hepatomegaly.
Yeah.
If the liver is just big, you don't treat the liver, you treat the underlying cause. If it's congestive heart failure causing blood to back up into the liver, you treat the heart. If it's alcohol-induced, you stop the alcohol. It's about finding the source.
Okay, that makes sense. Now, let's get specific. What about the liver abscess? The war zone.
This is a critical one because early treatment is absolutely life-saving. If it is pyogenic, so bacterial, you need two things. Strong antibiotics to kill the bacteria and drainage.
You have to get the pus out.
The old surgical maxim. Ubi pus, ibi evacua. Where there is pus, let it out. We usually do this with image-guided drainage. We use the ultrasound to guide a tube right into the abscess and we just suck it dry.
And if it's amoebic?
This is a classic trap for young players. Amoebic abscesses are treated differently. The primary treatment is a drug called metronidazole. It's incredibly effective at killing the amoeba.
Do you drain it?
Usually, no, and that's the key distinction. Unless it is absolutely massive and about to burst, or it gets a secondary bacterial infection, we try to avoid draining amoebic abscesses. The drug works on its own.
So bacterial equals drain, amoebic equals drugs.
That's a key distinction to remember.
Okay, now we arrive at the one that honestly sounds like a horror movie plot. The hydatid cyst, the parasite.
This requires extreme caution. The treatment involves a drug called albendazole to weaken the parasite. But for the cyst itself, we often do need to intervene.
But there is a massive warning here from Dr. Kumaran, a big do not cross line.
Yes, and if you remember nothing else, remember this. Never aspirate a hydatid cyst blindly.
Let's paint the picture for the listener. You see a fluid-filled sac on the ultrasound. It looks just like a simple abscess. Your instinct is to stick a needle in and drain the pressure. Why is that a potential catastrophe?
Here's the nightmare scenario. You stick that needle in, the cyst is under high pressure, you puncture the wall, and high-pressure fluid leaks out into the abdominal cavity. That fluid is filled with millions of microscopic protoscolices.
Baby tapeworms.
Baby tapeworms. So first, you've just seeded the entire abdomen with new parasites. You've turned one cyst into 1,000. But that's not even what kills the patient on the table.
What kills them?
Anaphylaxis. The fluid is foreign protein. It is highly allergenic. The second that fluid hits the patient's bloodstream or peritoneum, their immune system goes nuclear. massive histamine release. Their airway closes, their blood pressure drops to zero. You can lose a patient in minutes from anaphylactic shock.
All because of one well-intentioned needle prick.
Exactly. It's terrifying.
Yeah.
It really drives home why diagnostic aspiration, just poking it to see what comes out, is a forbidden move, if there is any doubt.
You have to be sure.
You must rule out hydated by history, the sheep and dogs, and by serology before you ever put a needle in a liver cyst.
So how do you treat it safely?
We use a special technique called pair puncture, aspiration, injection, reaspiration, but it's done very carefully with specific chemicals to kill the parasite first, and with strict anaphylaxis precautions. Or we do formal surgery to remove the whole cyst intact without spilling a single drop.
Okay, recovering from that parasite nightmare,
No.
let's talk about the gallbladder carcinoma.
This is often a very tragic diagnosis. The typical patient is elderly, often a woman, with a 20-year history of gallstones. She finally comes in with weight loss and jaundice.
And what can be done?
If we catch it very early, which is unfortunately rare, we do a radical cholecystectomy. It's not just taking the gallbladder out. We have to take a wedge of the liver bed where the gallbladder sits and strip all the lymph nodes around the area. It's a big, aggressive operation.
And if it's found late?
If it presents late, which it usually does because the symptoms are so vague for so long, it is often inoperable. Then we move to palliative care. We can put stents in the bile ducts to relieve the jaundice and the itching, we manage their pain, and we try to give them the best quality of life possible. But the prognosis is generally poor.
It really emphasizes why catching those early, vague symptoms is so important, and why ignoring silent gallstones for decades does carry a real risk.
It does. A small risk, but a devastating one.
And finally, the other causes you mentioned.
Hepatic flexure carcinoma, that's colon cancer, requires an oncological resection. You remove that part of the colon. Renal masses go to the urologists. Once we verify it's not the liver, we hand them off to the kidney team.
We have covered a huge amount of ground here. We started with a simple box in the belly and ended up with a life-saving checklist.
And that is the whole point. This method, Dr. Kumaran's method, is all about discipline. It's about fighting that urge to panic and jump straight to technology.
Let's recap the flow one last time for the listener, if they're driving to work and want to remember just the skeleton of this deep dive.
Okay. 1, think anatomically. Know who lives in the box, liver, gallbladder. 2, interrogate. Ask about speed, pain, and fever. 3, search. Verify the mass moves with respiration. Is it hard like cancer or tender like an abscess?
That's 4.
4, investigate. Ultrasound first, don't shotgun. And 5, manage. Don't stick needles in cysts unless you are absolutely sure it isn't a parasite.
And the core takeaway through all of that.
Treat the diagnosis, not the mass. Don't just look at the lump. Understand the story, the pathology behind it.
I love the final aphorism our expert source leaves us with. Structure in thinking prevents errors in surgery.
It's true for surgery, and honestly, it's true for any kind of critical thinking. Chaos leads to mistakes. Structure leads to safety.
Well, that wraps up our deep dive into the right hypochondrium. But, you know, the body has 2 sides, right?
It does. And the other side has its own set of mysteries.
Exactly. The next logical step in this series, which we'll have to tackle another time, is the left hypochondriac mass. The spleen. It's a whole different beast with its own set of rules.
And we will apply this exact same rigorous structure to decode it.
Until then, keep asking questions, keep looking for the patterns, and thanks for listening to the deep dive.
Stay curious.